We are on live, sir.
Ma'am, we are on live and we are starting the session, ma'am.
Yeah.
So very good evening, doctors and delegates. Welcome you all for the today's webinar. I'm Dr. Stalin on behalf of Shield Healthcare, welcoming you all for the today's webinar. So the topic for today's webinar is, does stress actually affect infertility? So this is one of the topic where much discussion must not be happening. So we brought this topic for you, which will be interesting. So I welcome all the delegates. I request you to post any queries, if any, in the chat box, so that we can have a short QA session at the end of this presentation. And now it's time to introduce our invited speaker for the day, Dr. Nithya Ramachandran, ma'am. Madam has done her MBBS, MS OG, MRC OG from London. And Madam is currently the founder of Eye Care Specialty Clinic, Chennai, visiting consultant at Apollo Cradle, Cloud9 and Motherhood Hospitals. So Madam has a very huge experience in infertility and gynec as well. So Madam has undergone various trainings and robotic. Madam is also a robotic endoscopic surgeon. With this short introduction, I welcome you, ma'am. I'm handling the session for your presentation. Welcome.
Thank you. Thank you so much for your introduction, Mr. Stalin. Okay. So shall we go ahead with the topic?
Yeah.
So today's topic of discussion is about stress and infertility. So we know about infertility a lot. Now, I think about 20 to 30 million couples in the reproductive age group are suffering from this issue of infertility in our country. Now, what do you mean by this word called stress? So stress is something which will equip us to face any challenge. So in day-to-day life, we have a lot of stress. For example, if you have to get ready and come to the hospital on time, it is a stressful situation because there'll be traffic and you have to take your car, go out, you have to reach at that particular time. That itself is a stress. Then you have to get your children ready to school. For example, for those work at home, moms who are at home, send your husband home, send your husband to office, send your children to school. That itself becomes stressful. Now, because of all this stress, we cannot remove any of these stress factors. But what we can do is we can handle these stress in a better way. So that is what we are going to talk about, stress and infertility today. Now, what do you mean by reproductive age group? Reproductive age group is a girl who is between 15 years to 44 years. So that is what is called reproductive age group in India. So in India, 1 in every 4 couple in the reproductive age struggle with subfertility. Now we are seeing that, more and more Indians are finding it a little difficult to conceive. If we have to put this in percentage, at least 10 to 15% of married couples are experiencing fertility issues. Now, before we used to tell that, fertility means it should be only, majority of the reason will be women. But no, it is not. About 40 to 50% of cases are attributed to even the men of the family, of our country, and the rest belong to the women. Now, surprisingly, even male infertility is on the rise in comparison to female infertility. Now, so long, what are the factors that have impacted the infertility rate in India? So about 40% are male factors, as I told, and the rest of the 40% can be female factors. About 10% is called as unexplained infertility. This is the most difficult thing to handle when we don't have much to offer the couples. We just tell them we don't know why you're not able to conceive. Now, what all factors can affect this infertility? It can be, you can see in the chart here, a yellow color which shows that unhealthy eating habits. This is the major reason for most of the problems in our country. For example, starting from diabetes to hypertension to obesity and even up to infertility. The rest can be polycystic ovaries or stress. And also in the red thing, we can see in the red graph that it is about older couple. So older age of marriage. That is also one of the main contribution for infertility. So now what happens when a couple is not able to conceive? About 1 year, if they have had regular intercourse, and if they're not able to conceive, then that is the time when they approach a doctor. And at that time, we tell them, we do different investigations and we tell them why they are not able to conceive. Now, the moment we tell them, there'll be a lot of emotions. By that time, the couple would have discussed a lot among themselves that what could be the problem. So the first thing is they are shocked that they have such problems. For example, if we tell a woman that she's having polycystic ovaries because of which her ovulation is delayed, the first thing she does is, no doctor, so many days my periods were normal. How did polycystic ovary, suddenly come to me? So this can be one of the, so it is shocking. And anything, a news which we don't like, we deny it. So a denial mode can be there. Next, there can be anger and frustration. Like, why should it happen to me? I am so healthy. I eat properly. I go to gym. I go to yoga. Still, why I am not able to conceive? I am so fit. Why is this happening to me? That can happen. Next, there can be, isolation, where if you have a problem, you start moving away from your partner. You feel that, no, maybe I am not appropriate for him. I'm not able to bear his child. Such feelings also do come to a woman. Next, there can be a sense of a loss. For example, even if the woman has conceived, she might have recurrent pregnancy losses because of some unknown reasons, and this can lead to a sense of loss in her. So all these reasons can, it's going to, this is what the people feel once they are told about their infertility condition. Now, can stress attribute to fertility, or can it be one of the contributing factor? Yes, it can affect. To what extent, we will see now. And this is one more important slide where social stigma can aggravate the stress levels. So I insist on all the couples who come for consultation to me, just close your ears. Don't listen to anybody who's around you. Maybe it's your mother-in-law or father-in-law, or it can be your parents, or it can be any uncles and aunties who are distant cousins to anyone. Do not listen to them. Just close your ears. Half the people are not bothered about your problems, and the rest half cannot solve it. So there is only one person who is bothered, must be your husband and your close circles, and next will be your gynecologist. So let's come to proper stress and infertility. There is a definitive link between stress and reproductive dysfunction. So the psychological stress that is experienced by female and male partners are associated with lower conception rate. Now, what all levels this stress can affect? It can cause, first, it can cause loss of libido, both in both male and female. Next, it can reduce the sperm quality, the ovulatory capacity, and also the implantation rates in women. So how does the stress affect these reproductive function? We will see. As I told you, it is going to reduce the libido. It is going to affect your GnRH pulse generator at the level of the hypothalamus. Next, we come to the pituitary level. So there'll be reduction in the pituitary hormone levels like FSH and LH. Then this is going to act on the uterus. So there'll be reduction of estrogen and progesterone. So we know that all this is going to reduce your conception rate, because ovulation is going to get delayed. Now we have two important axes that we have to discuss about. So we have hypothalamo-pituitary adrenal axis and hypothalamo-pituitary gonadal axis. So let's just keep this simple. So you have the hypothalamus, then you have the pituitary gland, and then you have the adrenal gland. So what happens in this HPA axis? Once there is a level of stress in the body, from the hypothalamus, your corticotropin releasing hormone is going to release. This is in response to any stress. So once CRH is released, what happens? It acts on the anterior pituitary gland. Now, from the pituitary, adrenocorticotropic hormone, or your ACTH. This is the basic physiology which we've been studying from our 12th standard and our MBBS days. So once ACTH hormone is released, it is going to secrete our glucocorticoids from our adrenal gland. Now, this glucocorticoids is going to, why is glucocorticoid released? The major function of a glucocorticoid is to regulate glucose and fat utilization, and storage of fat and memory, immune function. That is, it is going to help our body cope up with stress. That is why glucocorticoid hormone is released. Now, this glucocorticoids can also go and have a negative feedback inhibition on back to your hypothalamus. So it is going to stop the secretion of CRH and ACTH. Now let's see the next. That is hypothalamo-pituitary gonadal axis. So in hypothalamo-pituitary gonadal axis, what happens is you have two neurons which are very important. One is KIS1 neurons, which is the kispeptin neurons, and gonadotropin inhibitory neurons. All right. So once these two, we know that the name suggests that KIS1 neurons is going to stimulate your GnRH, and the GnRH inhibitory neurons is going to inhibit them. So once your GnRH neuron is released, it's going to stimulate your FSH and LH levels, and it will cause the ovaries to produce, it is going to produce estrogen and progesterone from the ovary. Now, just imagine that there is a level of stress and GnRH inhibitory neurons are released. So what happens is your FSH and LH is not going to come here, and there is going to be disruption of the whole cycle. Now, are these two related? This HPA axis and HPG axis, it is related. Everything works as a team in our body. Suppose there is a level of stress, what happens is your CRH hormone is released. And this corticotropin releasing hormone is going to directly inhibit your GnRH release from the hypothalamus. So once the GnRH hormone is inhibited, what happens? We know the rest of the cycle. The FSH and LH is going to reduce, and this FSH and LH is going to reduce your estrogen and progesterone from the ovary. Next, your GnRH hormone and your CRH hormone is also released. What does your corticotropin releasing hormone do? As we already studied, it is going to release ACTH, and this ACTH is going to stimulate from the adrenal cortex. It's going to release glucocorticoids. Glucocorticoids will in turn inhibit the ovary also, and it inhibits the ovary, and it also causes a negative feedback inhibition by which GnRH released is again impaired. So, this becomes a vicious cycle. One more thing that happens is at the level of stress, noradrenaline, the beta sympathetic hormone beta sympathetic activity is going to increase in the body, and that is going to go and act on the ovary, that in turn cause multiple ovarian cysts. This could be one of the reasons why we see multiple ovarian cysts in ovary, whereas it is not polycystic ovary, but it can become a multicystic ovary because of this stress. Do we have evidence for all this? We are in the era of evidence-based medicine. So whatever we have told, what does the research convey? Let us have a look at this. So here we have an article from Therapeutic Advances in Reproductive Health. So there are evaluation of predictor factors of psychological distress in women with unexplained infertility. We see here that anxiety and depression symptoms are common among women with unexplained infertility, and we need better strategies to give them better support to cope up with this stress levels. Next, we have another article in the Human Reproduction Journal. So here the question, what did they study here? Here they studied the prevalence of psychological distress and moderate to severe depression with recurrent pregnancy loss. So is there a relation? So it was proven that compared to the general population or the women who have not conceived, the women who have had recurrent pregnancy losses, her stress levels are found to be higher. And there's another article, which was, the study was done in Yard Infertility Center, and it was shown that women with infertility have a significant impact on their mental health. So you cannot just brush aside the mental health part of infertility. That is why all the infertility centers now have somebody called as counselor or a psychological analyst who is going to analyze the psychological capacity or the stress handling mechanism of the infertile couple. This is another journal which was in Middle East Fertility Society, and this tells that 22% of infertile patients in the clinic, they experienced stress. Mainly it was the duration of infertility. If you've just started treatment for about 1 year, you may be like, okay, fine, maybe I'll conceive in another 4-5 cycles. The doctor is giving me treatment. But the moment this gap becomes longer, the stress levels increase a lot, and this can in turn impair our infertility levels. Now let us see how it separately affects the women and in man. Now compared to coming to women, we have an Elsevier article which says that stress-induced anovulation is about 34% when compared to the all others, and anovulation that occurs because of stress is much more higher. Now, how does stress affect ovulation? Imagine a person is under chronic stress. The hypothalamo-pituitary adrenal axis is getting activated. Now that is going to increase your cortisol level and your corticotropin releasing hormone level. Once these levels are high in the body, it is going to release your reproductive, it is going to suppress the reproductive hormones. Once the reproductive hormones are suppressed, that can lead to abnormal ovulation, anovulation, and also amenorrhea. This stress is one of, so you can see that in girls or in young women who are recently married and who are very much stressed all through, maybe it was a work pressure or it is something else, their cycles is the first one which is going to get hit. So that is how we tell that stress is affecting ovulation. Now, how there is one more points which we can tell how stress affects ovulation. Because of the stress, we can see sudden LH surge. So this LH surge we usually see at the time of ovulation. Now imagine the ovaries are not prepared to ovulate and there is LH surge that is happening in the body, then the other ovaries will start becoming cystic. It's not able to release it because there is premature LH surge, which can happen in patients with polycystic ovaries also. So similar to that, because of stimulation of LH secretion, there is a premature LH surge that is going to affect follicular maturation and also ovulation. And elevated LH concentration at different stages of menstrual cycle will have different effects on the maturing follicle and on the developing oocyte. This can even lead to early pregnancy loss because egg is not going to get implanted because the endometrium is not still prepared to receive that egg. Next is, once there is stress in the body, see, this is an article which was in Journal of Biomedical Science. So what it says is, once there is stress and because of pressure demands, or it can be some environmental factors, it can be your work related factors, and there are a lot of unknown factors are also there for stress. So there is, and apart from this, your lifestyle, for example, you're consuming too much of alcohol to cope up with stress, or you're smoking, or you can have other habits for which you're coping up with stress, which is not appropriate. This can also release reactive oxidant species. We've been reading about oxidative stress or oxidative species everywhere. So what does this oxidative stress do? It is going to go and directly damage the oocytes. That is, it can cause granulosa cell apoptosis. So because of this apoptosis, there's going to be cell death, because of which there's going to be estradiol level is going to reduce. And once there is oocyte apoptosis, there is reduced growth and development of the oocyte. Once this happens, there's going to be reduced oocyte quality. Once the quality of the egg is not good, there's going to be poor reproductive outcome. So oocyte quality is going to be definitely affected by the stressful life events, which is going to cause release of corticotropin releasing hormone, and there is impaired follicular maturation in the ovary. Next, as we saw in the previous slide, there is maladaptive behaviors like alcohol, cigarette consumption to combat stress. That can also lead to poor oocyte quality. Next, stress. Stress itself can cause poor IVF outcome. Next, we spoke about reactive oxygen species also. Now we saw that stress is going to affect the ovary. Now let us see, will stress affect the endometrial receptivity? Does it have any effect on the endometrium? Yes, it has. It shows that stress is a common factor for development of unexplained reproductive disorders. So the endometrium, if it is not prepared to receive that egg, then it can lead to miscarriages, and it also is going to affect the quality of life and psychological status also, or psychological status of the individuals. So here we can see that what is the impact of stress on the human endometrium. So once there is stress, again, coming back to the previous thing only, HPA axis and you have HPG axis. Because of HPA axis, cortisol is released. So glucocorticoids is going to come, and these stress hormones is going to act on the endometrium and it will cause endometrial dysfunction. Similar to the human, hypothalamo-pituitary gonadotropin axis is going to get disrupted. So there is reduction of GnRH, and on the ovary, there is lower level of GnRH, because of which there is lower FSH and LH. There is altered secretion of estradiol and progesterone. So there is inhibition of the epithelial and the stromal cell proliferation. There is inhibition of cell differentiation. So basically all the cells in the endometrium is getting disrupted. So altered endometrial gene expression. So endometrium is not ready, or it is not receptive to receive the egg. It is going to affect implantation and development, and this can lead to miscarriages. Now coming to male. Does it affect equally in men also? Yes, it does. According to the ASRM, infertility affects men and women equally, and semen quality is the most key indicator of male infertility. So a patient walks in, a couple walks in, apart from investigating the women, we do investigate the men also. And in the men, the first and foremost, which is going to give us everything about the man, is going to be, that is the first test we offer, is semen analysis. So men who feel stressed are more likely to have lower concentration of sperm, and the sperm are more likely to be morphologically abnormal. So this may, stress may trigger the release of steroid hormones and, for example, the glucocorticoids, which in turn is going to blunt the level of our testosterone and sperm production. Another reason could be oxidative stress, similar to the partner which we have seen. Now, this is an article which was in Journal of Andrology, effect of psychological stress on fertility hormones and semen quality. So we saw that this HADS, you can see the word HADS in this, that is hospital anxiety and depression score. So here they've taken hospital anxiety and depression score for the patients who are coming to them. And we see that patients who have high anxiety and depression score have lower levels of testosterone, GnRH, sperm count, and sperm motility. Everything is reduced in such patients. How does exactly emotional stress affect the sperm quality is, see what happens. We can see two images here. So in the first image, you see that the sperm has undergone apoptosis. So by apoptosis, it's going to be self-damage or self-destruction. So here what happens, the sperm will be abnormal in shape. All the mitochondria gets aggregated to one another. So it is called as apoptotics. It has got undergone apoptosis. The next thing is sperm can undergo necrosis. Necrosis is complete death of the sperm. So here what happens, the acrosome of the sperm is very sparse in content. That is, there is no, there is aggregation of the chromatin, and there is a absent acrosomes and broken plasma membrane. So these are the signs of necrosis which we see. So this is the evidence to tell that stress is going to affect the sperm quality completely. So this needs definitely a treatment. Now this is in assisted reproductive technologies. So here we saw that this was to tell you about the norepinephrine levels or the stress hormone levels in pregnant population and in the non-pregnant population. So here we can see that in the patients who have undergone pregnancy, because of infertility treatment, their norepinephrine levels are much lower compared to the patients who are not able to get pregnant. So with the dotted lines, we see that is your non-pregnant patients. So in them, the levels of cortisol and the levels of norepinephrine are much higher. The effect of psychological distress on IVF outcomes. So is it true that this is an article which tells us that rate of stress, anxiety, and depression among IVF patients are higher than in general population? And if you want to get IVF, if infertility related stress is higher, then the IVF success rate is going to be lower in such women. Now, this is another evidence to tell that prevalence of depression symptoms among infertile women are much more higher than the general population, which we cannot ignore. So this levels of stress cannot be there for the women. This is going to inhibit them from achieving a healthy pregnancy. Now, this is a journal which was in Psychotherapy and Psychosomatics. It's a research article. So we all know about ICSI, that is intracytoplasmic sperm injection. Now, if the stress levels are managed during this procedure, then there is an outcome which tells that it improves or it influences the granulosa cell physiology and the embryo development kinetics in participants. So basically, the ICSI outcome is going to be good after you handle the stress levels. So impact of stress on fertility. So we've spoken so much. So how do we know that the patient is stressed? This is one thing which we have to find out. So the patients who have infertility, they may not always go to a gynecologist directly. Few people have somebody called as a family physician concept. So they may go there. And it is a duty of every doctor, whoever is seeing a patient who is unable to conceive, always consider their mental health status. Just find out how they are. What is causing so much of, is there any stress level which is attributing to this infertility? And infertile patients respond to stress of being unable to conceive by aggressively what happens is they want to conceive so fast, so they're ready to spend any amount of money, but they don't understand that until and unless the stress factor is removed, this infertility procedure may not be successful. So patients start withdrawing from family, friends, and community, and there can be some marital problems between the couples. Now, we have seen that even if the patient, we have found the cause of infertility could be endometriosis or it could be polycystic ovaries, for which we have given treatment. For example, even if surgery has been done for endometriosis and for low sperm count, if we have done the treatment also, this high level of stress, it's only going to make the pregnancy be more difficult. It is not, so we should know that the mind and the body should be in sync. Only then any treatment or any procedure is going to bring the outcome that we have expected. So couples participating in IVF program are highly stressed after a failed IVF cycle. This we have seen. No IVF cycle is going to guarantee them 100% success. So after so much of time and energy and money that they have spent, if they are carrying this baggage of stress with them, then it is going to be very difficult for them to achieve a pregnancy. Now, in IVF procedures, why the stress level is so much? If the patient is not able to conceive after 1 year itself, the stress level increases. Now, if they are IVF procedure, after undergoing IVF procedures, why they are so stressed? The reason is, see, they have to, if they may be a busy couple, they have to take time for appointments, and in a busy city, to travel from one place to the doctor's appointment clinic is another thing that is time consuming, and it is difficult, and it is draining out energy. The next thing, they have to get their blood drawn, repeated pricks. Next, they have to be examined every time, and it can be a per vaginal examination. Next, there should be multiple ultrasounds, and there are a lot of injections, and any injection will have its own side effects. Next, timed intercourse. This is one thing, it puts the couple in a lot of stress. Instead of enjoying what is an intercourse, they are going to be all the time stressed. Next, there are a lot of diagnostic procedures. And last but not the least, a much more important factor, it is a cost factor. So cost factor itself can cause stress in a lot of people. Next, what is the efficacy of reduction of stress before fertility treatment? Now, we have evidences to tell that there should be counselors in every IVF center, so that before the patient goes in for IVF treatment, they are counseled well. What they can expect. It should not be their expectations are too high, so that when they are not able to meet that expectation, they get more and more stressed. All right. And the recent studies indicate that stress increases the dropout rates of treatment. We have seen many people, who have come for treatment for 2 years. After that, they have dropped out because it did not click. And this one of the reasons for this dropout is they are not able to handle the stress. And there is a recent meta-analysis which show that psychotherapy should be accompanied by IVF. It brings better outcomes. Now, there are short-term goals for male and female infertility patients. So what we do here is, first thing is, there should be a reduction of feeling of helplessness through coping with infertility. This feelings of helplessness is what we term as depression. They may be going into depression. And there should be modifications of negative cognitions. They may have some negativity about infertility. We have to bring that out. Next, overcome the deficiencies in knowledge about infertility. The best thing you can do to a patient is give them a lot of knowledge about it. Tell them, we may not be able to tell why they are not able to conceive or why IVF is not being successful, but still we can give them the knowledge that what can be the percentage that you can expect that it can get successful. Next, improve the communication skills. Marital communication skills, that is in between the partners, they should be in sync of whatever is happening, so that they are able to support one another when pregnancy does not happen. Now, there are two main factors which will appear in chronic stress that can determine what influences the mood or the psychological state of the couple at their fertility treatment. Number one, how the person is handling stress. See, all of us handle stress in different ways. Some people, they are very much self-motivated. So once a stress factor comes, they are able to face it in a better way. Some people go it in a bad way, like smoking, alcohol, that actually deteriorates with time. So that is the coping factor we have to see. Next, second factor is how the person handles his self-esteem, his or her self-esteem. Some people go down very badly, that they are not able to conceive, whether it is a man or a woman, that they're not able to achieve a pregnancy. So they go down very badly. So their self-esteem is affected. So this results from knowledge that something is missing. If the woman is not able to conceive, she feels that I'm not able to give my husband a child. So, her self-esteem goes down very badly. So they start isolating themselves. So this can affect the outcome of fertility. Now, so we have to concentrate on both the factors, how they cope with fertility and what is the how is their self-esteem, how we can bring up the self-esteem. Now, in our country, especially religious and social beliefs could be considered markers for fertility related stress in their own right. So that we have a lot of religious beliefs and all that. So that itself can lead to stress in couples. Now, is it very important to establish stress levels before fertility treatment? Yes, it is. As I told you, whoever you may be, you may not be a gynecologist, you may be some other specialty, but still, it is our duty to find out if there is any stress levels in that patient. And maybe you just talking to a patient may bring down the stress levels. But how do we find out that the patient is stressed? Is with questionnaires. So you should have some which the psychologists or the therapists in all the IVF centers do have the levels of questionnaire. Now, once we give them a questionnaire, if we find that the patient is a little bit, they're not able to handle stress or they're going into depression, we give them treatment for this. It can be the treatment will establish the stress levels and it will also treat them. And again, after 3 months, we're going to see how it have they become better. So here you can see that one patient is diagnosed with infertility, establish the male and the female chronic and acute stress levels with questionnaires. Now, if it is above the threshold value, then you give them intensive stress reduction techniques for about 3 months. It can be a talking therapy, it can be a psychological behavioral therapy, a cognitive behavioral therapy with these patients. And after 3 months, you're going to again assess these patients. Then with psychological and biological assays. If they are still over the thresholds, you continue the treatment for 3 more months and simultaneously we start the treatment of infertility. Now, for example, an old couple come to us. For example, they are above 35. Obviously, we do not wait for the stress levels to come down. We simultaneously start the treatment and then go hand in hand with this therapy. Several studies present promising results of psychological interventions leading to higher pregnancy rates. So this is what we have to remember. Once the couple is stressed, we have to tell them how to handle their stress. We may not be able to remove all the stressful factors, but yes, we can definitely help them and give them options how they would handle the stress. That is the adaptive response. So what are the interventions for stress control and fertility treatment? Number one is procedures. So procedural means. So protocols to include patient selection according to, we should give treatment to patients so that they'll be able to handle the failure rates. So you always tell them, so if we give this treatment to you, this can be the success rate and this much can be the failure rate. Next, always have a preliminary treatment to reduce the anxiety and the depression before fertility cycles are initiated. Next, we come to our psychological means. Psychological means, as I told, it can be cognitive behavioral therapy, it can be a relaxation technique, you change the orientation about infertility to them. That this is not the only aim in life to have a child. There are other things also. So probably like this, you will be able to give them a different orientation. Next one is fertility sabbatical permit. What I mean by this is tell them to take a break. By just taking a break, they may be able to conceive later. So that because the stress level is going to come down when they're going to take a break. Next thing, when technical means, what you can do technically is you can frozen backup samples taken at the low stress moment. Maybe now they are stressed, so you can freeze their eggs and freeze their ovaries. Next, you can have for if you're doing an ICSI, you can remove the acrosome. That is also one of the techniques that can be adapted. Next is neurobiological means. So establishing individual baselines and specific stress markers. Then establish the threshold for referring. And you always monitor the stress before and during the fertility treatment. There are presently available evidence support the following three assertions. So this is going to be our take-home message. That is, infertility causes stress in the couple involved. Yes. Infertility treatment per se also can cause stress in the couple involved. Next, stress may be a primary or a secondary cause of infertility. Primary cause can be endometriosis, but with endometriosis, I told you before that even if the patient is treated, still she's not able to conceive, one of the additional reasoning factors could be because of stress. So at each level, we have to tell the patient to handle this stress. stress management. So no one expects patients to approach fertility treatment stress-free. As I told you, stress is there at every point in our life. We have to know how to minimize them and when to take the treatment. What are the ways to reduce stress? So talk to your partner. That is one way. So couples who are taking the treatment for infertility or subfertility, always talk to one another, be in support of one another. We have to tell them this. Next, remember, you're not alone. So we have seen that infertility rates are increasing. So you're not the only couple who are facing it. You are not alone. What I mean is your partner is always by your side and your family should stand by it. Next, talk to the people with infertility through individual or couple counseling. There are a lot of support groups available, though it is less in our country, where, you know, talking about infertility among patients is they still feel that it's a taboo. Okay, and so we need couple counseling. Counselors are extensively available. Next, read books about info. You have to tell them to get knowledge about it, and which can help them to deal with the stress. Next is stress reduction techniques such as meditation, yoga, and acupuncture can be helpful. Avoid combating stress. Don't indulge in too much of alcohol, coffee, or other stimulants. Exercise regularly and reduce your physical and your emotional tension. Can supplements reduce the level of stress hormone levels? So there is a drug which is called as Oraspa. So what it contains is, it contains lactium 150 milligram with theanine 100 milligram. So here what happens, it can release, so let me tell you the mechanism of action. It is nothing but a milk protein hydrolysate. So it contains a bioactive peptide, decapeptide with anxiolytic properties. So this peptide is produced from milk protein, that is casein. It has been developed after, the company claims that it is developed after 12 years of research, and it does work as reduction of, it reduces stress and anxiety. It has no sedation effect and it does not cause addiction. So what does this lactium do? So as I told you, it's a milk protein. It is going to act on the hypothalamus. So it is going to prevent your CRH release. So corticotropin releasing hormone, if it is not released, it's not going to release ACTH. So in turn, the glucocorticoids will not be released. So there is no after effects of the glucocorticoid release. So the stress level is not there. So all those hormones are reduced. So there is reduction in cortisol and reduction in adrenaline levels. There is it is seen that 25% reduction in stress-induced cortisol level within 3 hours. So lactium reduces the stress-induced cortisol levels. It reduces the GnRH pulse and it normalizes the LH and FSH ratio. Normalizes in females, it normalizes estrogen production. It improves the equality. Obviously, when your stress levels are reduced there and your GnRH levels are going to be get regulated, FSH and LH levels are going to get regulated. So it will improve the oocyte quality and also normalizes the progesterone production. In males, it's going to reduce testosterone levels and also the sperm quality. Now, this lactium binds to omega-2 GABA receptor, so it improves the GABA activity. And there is no sedation also in this. Next, we talk about L-theanine. Theanine is something which we find in our tea. And so what it does is it increases the activity in alpha frequency, which indicates that it relaxes the mind, but it does not cause drowsiness. So the benefits of this drug in stress is it regulates the hormonal pathway, it regulates the neuronal pathway and also the alpha waves. The alpha waves is going to cause you good quality in sleep. And neuronal pathway is going to increase your GABA level and decrease your glutamate activity. So you are increased, there is coping mechanism of stress. And there is regulation of hormonal pathway, it reduces stress, induced cortisol and also adrenaline levels. So it regulates GnRH and in gist, it reduces your GnRH and gonadotropin levels, regulates estrogen and testosterone, regulates oogenesis and spermatogenesis, improves the regulates progesterone levels, and endometrial receptivity is also increased and it regulates the libido. So all this was getting suppressed because of stress and CRH and ACTH. All this is going to be improved. So the benefits of the drug is there is no addiction. As there is no addiction, there is no withdrawal symptoms and there's no sedation and there is no, and it is a better tolerated drug. So what is the take home message? We know that infertility can cause stress that leads to anxiety and depression. Stress can make it difficult for men and women to conceive. So it's 50% here and 50% here. And stress reduction techniques, when employed on regular basis, is going to improve the conception rate. Stress reduction is non-invasive, less expensive, and ethically acceptable way of improving fertility. The professional in reproductive medicine, we should always test for chronic stress before we start a treatment or adjust selection of the patient. So thank you. So just to complete this, see, you cannot measure stress. You can measure everything like AMH levels or everything else can be biologically or chemically, it can be measured. Whereas your stress levels, it cannot be. And when something cannot be measured, it does not mean it does not exist. It proves, I mean, it creates a lot of impact on the couple who are trying to conceive. So we as physicians or as clinicians, it is our responsibility to, you know, find out who is getting affected because of the stress and give them appropriate treatment. Thank you so much. Thank you for your patient listening.
Thank you, ma'am. Thank you very much for that informative session, ma'am. Yes, ma'am, as we discussed, this is one of the major topic where most of the discussion is not happening, ma'am. So this is one of the major contributing factor when it comes to infertility, ma'am. Thank you once again, ma'am, for accepting an invitation and for spending your valuable time with us today, ma'am. Ma'am, let me wait for 1 or 2 minutes for the participants to post their queries, ma'am. If there is any queries, then I'll read it for you, ma'am. Ma'am, I have few queries, ma'am. Like when it comes to infertility, whether the fertility rates are reducing only in India or worldwide, ma'am. Worldwide, the scenario is same or
worldwide, the scenario is same. In India, see, obesity is increasing.
Yeah.
Okay, obesity is increasing. Marriage age is increasing. So because of this infertility rate, yes, it is increasing in our country.
Okay.
Worldwide also it is increasing because of all these factors.
Okay, ma'am. Well, because most of the peoples were, as you said in the beginning, many of are going for the jobs, as for the higher educations. Those makes them stress, and whether it is contributing the infertility. That is what my question, ma'am. Ma'am, is there any one question, ma'am? Is there any guidelines for evaluating the stress level internationally, ma'am?
International level guidelines, I'll get back to you on this. Yes, because once we talk about stress, see, all of us have a psychologist who is there in the clinic, yes, IVF counselors who are there. They have a prepared questionnaire.
Yes.
You give me 1 or 2 days time, I'll get back to you on this questionnaire.
Yes, ma'am.
Okay.
Yeah, ma'am. One more question, ma'am. Whether this evaluating this cortisol levels, since being a stress hormone, whether evaluating or whether measuring this cortisol level or alpha amylase being a stress hormone, whether it will be useful for the doctors to evaluate that the person is under stress.
Yes, it can evaluate. But if the moment you tell the patient that they are going to see this for stress levels, the stress is going to increase.
Yeah, ma'am.
So
yes, ma'am. But when they're going for any general blood tests, like FSH or any hormonal test, during that time we can evaluate the stress level also, so that it is going to be a single test, ma'am. So they're going
some patients, no, they will believe only when you show reports.
Okay, ma'am.
Because of this hormone only, your level is like this. So for such patients, maybe we can give it to them.
Yeah, ma'am. So there are many unknown reasons also, no, ma'am. So, and it is, as you said, it is very important for both the couples to evaluate, ma'am, for stress. Yes. So that is also one of the major take-home message from this webinar, ma'am. So audience, if you have any queries, you can post here so that I can take it to the madam for her address. So I'll wait for 2 minutes. If there is any queries, Saiti, you can just post it here. I'm also watching here. So if there is any queries from YouTube, you can post it here. So this video recording will be available in the YouTube. So if you want to comment any questions, you can just post in the comment box in the YouTube also, so that we will take it to Madam, Dr. Ma'am, and we will be addressing all those queries also. So recorded version is available in YouTube. You can share with your friends also. Yeah. Ma'am, whether this infertility, that is stress evaluation, has to be done at the initial level of treatment or only when they're going for IVF? Ma'am?
No. It has to be done at the initial level of treatment. It is better.
Yeah, ma'am.
See, though in our OPD, we don't do it regularly. For example, a patient who is not conceived for 1 year, they come to us.
Yeah, ma'am.
We don't have a questionnaire to tell that they are under so much of stress. But when they go for IVF treatment, definitely there is.
Yeah.
But what I feel is if you want to stop going to that IVF level, if a basic treatment can be done for them here itself, then we can start assessing the level of stress right in our OPD here.
Yes. Ma'am, whether this stress evaluation to be done throughout the pregnancy or only at the initiation of this pregnancy? So once they are
Initiation of treatment.
yeah, ma'am.
Yes, it has to be done at the initiation of treatment. And if you feel the couple is stressed, you refer them to a therapist. After the therapy, give the therapy at least time, give at least 3 months time. And then you can reevaluate them if it is doing good to that couple.
Yeah. So participants, if we don't have any questions, then we can end the webinar for today. Saiti, is there any questions, Saiti?
No, sir. No, sir.
Ma'am, there is no questions, ma'am. If they are posting any questions in the chat box, then I will post it. I will forward to you, ma'am. You can address on those in mail, ma'am. Thank you, ma'am. Thank you very much once again for being with us today, ma'am. And I also like to thank the audience for their active participation. Ma'am, we will share the details of the participants and the recorded version with you, ma'am. You can just go through.
Thank you so much.
We will send the recorded version, the link.